Magandang araw sa inyong lahat. Good day to all. I am Dr. Carmencita Padilla, one of the proponents of the newborn screening program in the Philippines. Join me in uncovering the wonderful story of newborn screening in our country. Together, let's zoom in on what makes newborn screening a comprehensive program for every Filipino. Here at Newborn Screening in Focus. To ensure that newborns are truly healthy, they must undergo newborn screening, a public health program that helps determine if a baby is born with one of the more than 20 congenital disorders. Its importance cannot be overemphasized. If any of the congenital disorders is left undetected and not managed immediately, it can lead to mental retardation and even death. It was integrated into the public health delivery system with the enactment of Republic Act 9288 or Newborn Screening Act of 2004. Now part of PhilHealth's newborn care package, newborn screening is being offered in more than 7,000 hospitals and birthing centers nationwide. It has also saved thousands of children. This educational series is intended for health professionals who deliver services of the newborn screening program. Whether you are online or offline, this program aims to further enrich your knowledge on newborn screening and be able to apply the highest quality service to Filipinos, especially during challenging times. We will discuss the very process of newborn screening from the moment the child is born and into the continuing care available for newborns found positive. We will also zero in on the features and management in each of the conditions included in the newborn screening panel. We will also interview patients as well as their parents. And in keeping up to the challenges, talk over how facilities and centers manage to give quality service despite the limits brought about by the COVID-19 pandemic. This program is the newest educational platform for our newborn screening coordinators, one in every 7,200 health facilities throughout the country. We hope that this series will also benefit the health professionals, physicians, nurses, midwives, medtechs, as well as students in the health professions. So take a seat, get comfortable as you're in for quite an adventure here at Newborn Screening in Focus.
Ako po si April Grace Viloria, taga Palawan. Nag-iisa po akong anak at siya po ay mayroong case ng Congenital Hypothyroidism. Ngayon po siya ay 3 taon na. Sa clinic kasi ako ng anak, no? Tapos, syempre, tuturo din po nila kung ano yung process ng mga test, mga kailangang i-comply na test. In-endorse kami ng clinic na newborn screening. Na-receive ko po yung result na may congenital hypothyroidism siya. Since nalaman ko po yung case niya na positive, CH baby, may nurse sa PGH na nagko-contact sa akin. Siya rin yung nag-explain sa akin ng case. And then after a week, contact naman ako ng PGH nurse. Kailangan ipa-test again to monitor yung kanyang FT4, FT3 at saka PSH. Kasi imbalance talaga siya, hormonal imbalance talaga. Humihingi pa rin ako ng guide sa mga nurses na nag-coordinate sa akin. So hanggang 1 year old, 2 years old, hanggang 3 years old na siya ngayon, pedia niya po yung nag-coordinate kay nurse, tapos ko-coordinate po sa pedia endo. So far, yung development naman ng bata, as long as meron yung gamot na maintenance niya, maganda naman yung development niya. Yung paglaki niya, normal. Yung lagi lang namin, kaya din okay yung anak namin ngayon, monitoring ng hormones. So, every 3 months at least, nakakapalaboratory po kami. Thankful po tayo sa panahon natin ngayon kasi mayroon na tayong newborn screening. So, before siguro, wala pa pong newborn screening, hindi pa agad-agad nalalaman na may ganitong case pala si baby. Thankful din po ako sa PGH kasi yung laboratory, sa totoo lang po, lalo na kung wala kang trabaho sa panahon ngayon ng pandemya, mabigat po sa bulsa. With the help of PGH, nag-reimburse po sila ng para sa laboratory. So, huwag kang matakot. Siguro, mahirap, pero walang hindi kakayanin para sa anak.
Ngayon po, si Janelle ay 19 years old. Siya ay kumukuha ng civil engineering. Third year na po siya ngayon. Okay naman po siya. Normal po ang kanyang buhay. Maaring magkaroon tayo ng problema sa pinansyal, sa pagpapa-check up sa espesyalista. Pero kapag nalaman ninyo, kapag nakita ninyo na normal na lumaki ang inyong anak, mababaliwala lahat yun. It's all worth it.
Dahil sa newborn screening, naging normal ako.
Napaka-importante po talaga ng newborn screening. Ngayon po, nung naisa batas na ito, pero kailangan pa rin po maintindihan ng bawat magulang yung importansya nito. Hindi nyo po malaman kung sinong sanggol ang pwedeng tamaan nito. Kaya ang hirap pong makipagsapalaran at dalawang isip pa tayo tungkol dito. Bawat magulang naman ay kagustuhan lang talaga maging maayos ang kalusugan ng kanilang anak para masigurado na magiging malusog at magiging ligtas sa sakit ang kanilang anak.
Kaya dapat magpa-newborn screening.
For this episode, we will discuss congenital hypothyroidism. Congenital hypothyroidism, previously known as cretinism, is a severe deficiency of thyroid hormone in newborns. Babies with congenital hypothyroidism are born with an underactive or absent thyroid gland. Because the thyroid hormone plays such an important role in brain development and growth, all babies born undergo a screening test to check thyroid hormone shortly after birth. Congenital hypothyroidism is the most common endocrinological disorder detected by the newborn screening program in the Philippines. From 1996 to December 2019, a total of 13 million babies have been screened, of which 5,000 were confirmed to have congenital hypothyroidism or CH, giving a prevalence of 1 in 2,716. Early detection and treatment of congenital hypothyroidism generally results in normal growth and development. To talk more about it are two special guests, Dr. Lorna Abad, a pediatric endocrinologist and the chair of the Department of Pediatrics of the Philippine General Hospital, who will discuss the pathophysiology and management of CH. And Dr. Maria Isabel Quilendrino, a developmental pediatrician, will talk about the developmental concerns in patients with CH. So Dr. Lorna, Dr. Abad, so what is congenital hypothyroidism?
Well, congenital hypothyroidism is a condition where the body is not able to produce thyroid hormone. The thyroid gland is not able to produce thyroid hormone for several reasons. One is the thyroid gland is absent. And second is that there may be a thyroid gland, but for the production of thyroid hormone, there are several steps involved. So from iodine, there are enzymes that will convert that to eventually form thyroid hormone. So there are other causes, like there could be a thyroid gland, but it is not located in its proper place. And so the anatomy of that gland is not the normal anatomy of the gland. And so it's not able to produce enough thyroid hormone.
So Dr. Lorna, for the benefit of our paramedical audience, can you tell us the location of the thyroid gland?
Well, the thyroid gland is, if you remember the boy's anatomy, they have Adam's apple. So for girls, we don't have one, but imagine that a girl has has an Adam's apple. So it would be below below that Adam's apple. So if you look at your neck, there is a depression there. It's just around that area here. Like if you have older people whom you see with bulging mass there, yung goiter, we call it goiter, that's where your thyroid gland is. So when it is enlarged, it's called goiter. But in congenital hypothyroidism, we don't see that often because the most common cause is absent thyroid gland.
So Dr. Lorna, that's very difficult to actually see in a baby because the necks are really small. So and I think that will segue to the issue of finding another way of making a diagnosis. But before we go to the diagnosis, let's talk about the prevalence. Can you share the global and the local prevalence of congenital hypothyroidism?
So you've mentioned earlier that based on our local data, our prevalence is about 1 for every 2,700 live births. But if you go through worldwide incidence, it's about 1 in 3 to 3,500 live births. So you can see that our prevalence is higher than the global prevalence.
So Dr. Lorna, are there any reasons why the prevalence in the Philippines is a little bit higher? Because I know some places also in the world we're in, the prevalence is higher than 1 in 3,000. Are there any reasons for this?
Well, there could be several reasons. One is probably the etiology, the cause of the hypothyroidism. We know that the Philippines is one of the areas where iodine deficiency has not been addressed. We are not really 100% iodine sufficient. So it could be that most of the mothers, especially those in the not so affluent level, they may not have enough iodine intake. So they are low in iodine during their pregnancy. And this could increase the prevalence of congenital hypothyroidism.
So Dr. Lorna, it's one of the conditions in our panel. And can you share the signs and symptoms at birth and explain to our viewers why we decided to include this in our panel from the very beginning of the program, which is roughly about 25 years already?
This is precisely the reason why newborn screening is needed, because 95% of newborns will look normal. The only reason for a baby to have the not so classic signs of hypothyroidism is if the mother has severe iodine deficiency. But for a very astute health worker, one of the probable telltale signs that should make you suspect congenital hypothyroidism is if you have a baby with very big fontanelles, bumbunan. Not the anterior fontanelle, but it's the posterior fontanelle. So if the posterior fontanelle is more than 1 cm in diameter, that could be one of the clues. Second is if the patient is not able to control his or her body temperature, yung tinatawag na hypothermia, then you have to watch out that baby. So you have to insist that a newborn screening be done. And if there is delayed passage of meconium, so a baby will have to move his meconium, pass out his meconium within the first 24 hours. So a delayed passage of meconium should make one consider the possibility of congenital hypothyroidism. And of course, during the first week of life, the baby will not be feeding very much. Hindi siya demanding for feeds, unusually quiet. So, although of course these symptoms are very non-specific also for congenital hypothyroidism, they could be some of the clues that will make you really do a newborn screening, because the classic features will not appear until the patient is about 2 to 3 months old, by which time it's already late. It will already lead to mental retardation if treatment has not been started.
Well, thank you. Thank you, Dr. Lorna, for clarifying. Those are very important points. No, we have this misconception when you talk about malaking bumbunan, we're talking about the anterior fontanelle. What you're telling us now is that it's really the posterior fontanelle that we should be watching out. And second will be the second telltale sign will be your delayed passage of armeconium as a possibility. But as you said, no, that's the reason we have newborn screening, because 95% of the babies will not have this very simple telltale signs. So definitely we've put in as newborn screening as one of the ways of making a diagnosis. But then can you tell us now what happens, when a baby is screened and we get a few drops of blood, send it to the lab, and can you tell us a little now about what's the next step? Getting a positive screen is just one step. So what should a health worker do? And in our case, in our 7,000 hospitals, some of the coordinators are doctors, some are nurses, and some are midwives. So what should be the next step?
So once you get a positive screen, because I understand we used to repeat the screening before, no? So by all means, do a confirmatory test right away, because we have to start treatment within the first 2 weeks of life. So if you need, especially if your results come out after the 7th day of life, you need some time. You don't have to repeat the screening. Do away with screening, but go right away with doing a confirmatory test, which means you have to do both a free T4 and a TSH. And I would just like to point out that one pitfall, of course, of our newborn screening is that we make use of TSH. So there are forms of congenital hypothyroidism that might be missed with the screening program that we have. We have the so-called secondary congenital hypothyroidism that will be missed by our screening program. So my usual advice is, when I give lectures, is that a normal newborn screening for congenital hypothyroidism should not make a health worker complacent that this patient will not have congenital hypothyroidism because of that very small percentage of secondary form of congenital hypothyroidism, where newborn screening result will be negative, meaning that TSH will be normal for the cutoff.
Okay, so thank you, Dr. Lauren. I'm glad that we brought up the issue of the follow-up test. So maybe just for our viewers, especially for the coordinators, for each of the panel, we do have an expert panel, and the expert panel, let's say for CH, will comprise of experts, let's say in endocrinology. When a sample is taken and brought to the lab, a certain value will actually alarm the lab whether whether the patient has to be recalled immediately. So Dr. Lorna mentioned a couple of things. Number one, we have to do it immediately because we have to recall the patient because there's a time for treatment. And Dr. Lorna is going to talk about that. The second point that Dr. Lorna said is that you have to understand that this is a screening program and there is a next step that we will do, and that is a confirmatory test. Number 3 point that Dr. Lorna said is that we are looking at the primary causes of congenital hypothyroidism. We are not actually addressing the secondary types of congenital hypothyroidism, and we should not remove the role of the clinician in making a diagnosis. So is that a correct summary of what just you said, Dr. Lorna, that every clinician who handles a baby must always keep in mind that we should observe the patient, and if we see something wrong, then we probably have to do additional tests. Will that be a correct summary of what you just
very well summarized?
Okay, so thank you, Dr. Lorna. So Dr. Lorna, so again, to our viewers, it's so important that we do the test as soon as possible. Right now, we're saying that the test should really be done on the second, after the 24th hour of life, because so that the sample can be sent to the lab immediately, and the results can be run, and the results be sent back to the hospital. So let's look at timing of treatment, no? Because there seems to be the best time for treatment. So, Dr. Lorna, you talked about the making a treatment diagnosis at second or third month is too late. So, when is the best time to treat these babies with congenital hypothyroidism?
Based on all screening programs and researches for so long a time, it has been found that the best prognosis as far as mental outcome is concerned is if you start treatment within the first 2 weeks of life, before the 14th day of life. Because it has been found that especially if the hypothyroidism is severe, for every day that you delay starting treatment, you decrease your IQ by 1 point every day. So it is important that we start treatment, especially those with really, really very low free T4, by the 14th day of life.
Okay, so thank you, Dr. Lorna. That's a magic number, no? Day 14. So we're saying now for congenital hypothyroidism, that's our window of opportunity to treat the patient. So for our coordinators, you just remember, if the baby's sample was done on the second day of life, there's really time for the sample to be brought to the lab, and you're going to get the result within the first week, 7 or 10 days. Meron pang time para gamutin talaga ang pasyente. So we cannot postpone treatment on the babies because, as Dr. Lorna said, there are no symptoms, there are no obvious signs and symptoms, and after 14 days, there is the loss of 1 IQ point per day. So Dr. Lorna, let me just address, we have quite a number of questions here related all to treatment. And let me start by asking about, or maybe you can tell us first, what is the treatment? And then I can give you the questions that I have here on hand for treatment.
Treatment is very simple and very cheap. You need thyroid hormone tablet. So there's no syrup preparation. And what we advise the mothers is to pulverize the tablet on a spoon and then put a few drops of water and put directly into the mouth. One important instruction is the baby should not have been fed at least 1 hour before you give your thyroid tablet. And then the baby should not feed for at least 30 minutes from the time that the baby was given the medicine. You can dissolve the tablet in a few drops of water or a few drops of breast milk. But it is important to remember that you should not mix the tablet with soy formula. So soya formula should not be mixed with the tablet. Second, when you are giving vitamins to your children, to your babies, you should not give it at the same time that you're giving iron and calcium. But fortunately, we don't have calcium naman for babies. So iron should not be given concomitantly at the same time. They can give the iron supplement, but not at the same time that they're giving the thyroid hormone. And then ideally, when you start the baby on a certain time, example, 7 a.m., make it a point na you should give that medication within that same time range, siguro within 1 hour of that 7 a.m., so 6 a.m. to 8 a.m. Because you know that your hormones will be absorbed, and so there is a cycle of hormones, so that your body rhythm or your hormonal rhythm will not be disturbed. Try to give it at close the same time as possible.
So thank you, Dr. Lorna. So how much is this? Now let's just take a look at the newborn baby, like in the first few months of life. How much would a family spend for this tablet?
Well, the cheapest would be the lowest concentration. It would range from 6 to 9 pesos.
A day?
Yes.
So, definitely it's something really, really affordable. And just to remind the viewers that if ever you have families who have problems with spending 10 pesos a day for the treatment, please contact your DOH regional coordinator and we will make sure that the Department of Health can assist you with the treatment. If you think about it, it's even cheaper than the load that we are putting in our cell phone. So this is really affordable and available in the Philippines. Just 2 points. This is interesting. I'm hearing this for the first time. You should not mix it with soya. soy milk, and that if ever you will use your breast milk, a few drops of breast milk, you can mix your pulverized your tablet, and the timing, at least 1 hour before, the patient should have been free from any feeding and should not feed the baby for at least 30 minutes. I think, it's just really just making sure that there is no mixture. And so definitely it's available and it's affordable. And am I getting this right, Doctor? So as a baby gets older, the dose gets higher, right? Am I correct, Dr. Abad? Dr. Lorna?
We actually have recommended dose. So during the first year, it's 10 to 15 microgram per kilo per day. And then after the second year, it's about 7 to 10. And as the child grows older, the recommended dose will actually not be the same. But by the time the patient is adolescent, you simulate what the body normally produces. So it's about 3 microgram per kilo per day.
So what you're telling me now, Dr. Lorna, is that if this baby is diagnosed before 2 weeks of life and treated properly, the baby will grow up to be a normal child and adolescent and adult. So my next question to you now, Dr. Abad, who should be handling the patient? Because, this has been a, what will be the role of the different doctors handling the baby with congenital hypothyroidism?
So the baby should follow up with his or her own pediatrician. We only see the baby periodically to make sure that we are seeing the good results of treatment. But the pediatrician of the baby will really have a very big role, because that pediatrician or any healthcare worker looking after the baby should monitor the growth of the patient, the length of the patient, a very rough a very rough developmental assessment, because at least we know what are the normal that should be expected from a baby. So the pediatrician has a very important role, or the family physician, any physician taking care of the child. Sila, they're the ones who are in more constant and frequent contact with the patient. We only, especially me, if most of us endocrinologists, if they come from far, we just see the baby every 6 months, every year. And since we now have coordinators out there, the coordinators can just contact us. They don't really have to come to us just for checkup. It's the responsibility of the pediatrician of the baby and the coordinators of our facilities.
Thank you, Dr. Lorna. That's very heartwarming to hear that the role of the specialist is really in partnership with the clinician on the ground, no? And it can either be a health worker, no? Because if the baby is probably up in the mountain, or let's say in an island community, that should not be an excuse for getting the treatment. What you're saying now is that just coordinate with the pediatric endocrinologist, or in our case right now in the program, we have community clinics, as I have discussed in another episode, to ensure that the patients take their treatment regularly. We have set up community clinics all over the country so that a nurse and a physician is able to monitor them, and when needed, we'll be referring them to the pediatric endocrinologist. I want to share with the audience that we are in partnership with the Society of Pediatric Endocrinology and Metabolism Society. Did I say that right, Dr. Lorna? And they have been around the country doing the clinics for our patients in different parts of the country. So we've been talking, so far that if done properly and treated on time, these babies are supposed to be normal. But we do have babies who don't end up to be normal, and for many reasons. Before I go to the next guest, tell us, Dr. Lorna, why is it that some babies or some patients end up not to be normal? Because so far we've been saying that these patients should be normal, and as we saw in the other cases, they really grow up to be normal individuals. Okay, so what is the reason for this?
One important reason is non-adherence to the intake of thyroid hormone tablets. Some would miss the tablet. Some would just stop the tablet for no apparent reason, despite the fact that even at the first instance, we already emphasize that treatment should be lifetime unless we prove later on that this patient has that so-called transient or temporary hypothyroidism, but at least up to 3 years kung transient. No? Second is that I have found in my experience, some of them would forget that they should not mix the tablet with with the calcium, the iron, like that. And the third is they just stop. They just stop treatment. And if you miss one tablet, it's not ano naman, it's not detrimental. The life of your tablet is actually about 1 to 2 weeks. So the baby is assured that the thyroid hormone is there for at least a week. But if there is continuous missing out on this, then that will really defeat the early treatment that we started. It's actually really missing the tablet. I had a very bad experience. A patient went home to the province and the patient stopped treatment. And there was even an incident where the mother told me that a doctor actually told her that since the baby is normal and the results are normal, then the patient does not have to continue medication. So it was really pathetic.
So that's really sad. I think what Dr. Lorna is highlighting is the importance of partnership. So for the newborn screening program, recognizing the gaps that Dr. Lorna was mentioning, we set up the continuity clinics actually throughout the country. So right now we have 14. So in other words, when the patient has been picked up to be diagnosed with a condition, we do have somebody who sort of monitor them just to make sure that they're taking their medicine. And we have a doctor or a health worker or physician, a nurse or a midwife who's taking a look at the growth of that patient. So I hope that we all appreciate the importance now of the continuity clinics. And the continuity clinic actually is important 14 hospitals in the country right now. And every year we're trying to increase this number until eventually we have one in every province. So in other words, if the baby or the child start missing the taking the medication, we do have complications. But before I go to the other questions that have come up, Dr. Lorna, let me call in on our other guest, because we actually invited a developmental pediatrician, Dr. Isa, to tell us, just a few things on how can we pick up the problems in these patients, because they may be so subtle, but maybe this is an opportunity for Dr. Isa to help our viewers on how can they pick up these conditions. So thank you, Dr. Lorna, and we'll be back with more questions after I interview Dr. Isa. Dr. Isa, welcome. Welcome to Newborn Screening in Focus.
Hello, Dr. Padilla.
So Dr. Isa, so tell us, we've heard Dr. Abad, and she was saying that these babies are supposed to be normal, but we're getting patients who are not normal. So can you help our viewers with some guidelines on how we can pick up subtle problems in the children? Go ahead, Dr. Isa.
Okay, so for all children in general, there are recommended ages for screening them for developmental concerns. But children diagnosed with congenital hypothyroidism may be brought in earlier for developmental screening whenever red flags are recognized. So the general pediatricians do their monitoring and surveillance, and they watch out for red flags. Red flags pertain to delays in the attainment of age-expected milestones. For example, a red flag might be in the motor skill. For example, when there is head lag at 3 months, or when the child or when the baby isn't babbling yet at 9 months, that's a red flag, and that warrants a referral for a full developmental evaluation.
So I think that's so important. No, I mean, the health worker must know these red flags, and the red flags cited by Dr. Isa is that they're not really confined to congenital hypothyroidism, but what we're saying is that if you're not following the milestones, then we better check and find out if what's going on. So since we don't have enough developmental pediatricians also all over the country, can you guide our viewers on after the initial screen, what could they do with once they pick up the red flags?
Okay, so children diagnosed with congenital hypothyroidism can be followed by different pediatric specialists. So these include their general pediatricians, their neonatologists, endocrinologists, or their primary care physician. So it is important for all of these doctors to be aware of the monitoring protocol for these children and children in general. So when a red flag, as I said, is picked up, they are referred for further evaluation to a developmental pediatrician so that the problems are identified clearly and appropriate and early intervention can be started. Developmental pediatricians are all over the country, and our directory is online. You can see this in the website of the Philippine Society for Developmental and Behavioral Pediatrics.
So Dr. Isa, that's a very good point. No, you're saying that it should not only be the pediatrician who should be looking at these milestones, since most of these patients, if ever there's another doctor who's looking at the patient, take a look at the development, because if there is a red flag, then by all means refer. So my follow-up question to Dr. Isa is, in the midst of COVID, how do you do assessments for this patient? Because I fully understand that, holding the baby is very important when you're trying to examine. So what can we do now in the midst of our current situation? Dr. Isa.
Okay, so in the midst of our current situation wherein we may not be able to see the children face to face, and we can get in touch with them through telehealth. Luckily, developmental screening can be done to a great extent, even online. So this is done by eliciting concerns from parents. They are asked questions regarding their child's milestones and concerns about their children's behavior, skills, and learning can be elicited through a parent interview. So whenever a concern is raised, we address that, we probe deeper, and we are able to monitor these children's development through that online or telehealth service.
Oh, thank you for that information, Dr. Isa. So nothing should really stop us from making the proper referral, because it is possible. So just in case, we have the red flag and we're able to assess that there is a delay in the patient, can you share now what will be the next steps in terms of managing the delay? Of course, we're assuming that they have consulted the pediatric endocrinologist who have corrected the dose of the medication. But as Dr. Lorna said, hindi na pwedeng bawiin. Okay, so when there's a delay, there's a delay. So what do we do now, Dr. Isa? Assuming you've given an assessment that there is a delay of 3 to 6 months, what is the usual next steps for the family?
Okay, so as previously mentioned by our other guests, the priority in intervention is really early and appropriate medical management. But for children who, for one reason or another, miss this critical period of medical management and is detected to have developmental problems such as delay in motor and language skills or problems in learning and behavior, an individualized intervention program is created for that child to cater to the unique needs of that child and his family. For example, a child with motor skills delay or who has a problem in muscle tone may benefit from early physical therapy to improve that muscle tone and promote the attainment of the various developmental postures. while a child who presents with speech problems or feeding difficulties may benefit from an evaluation and early intervention from a speech therapist. Educational intervention, on the other hand, can be given for children with poor academic learning. But it is important to stress that at the heart of any intervention program is parent education and empowerment, because parents really play the biggest role in supporting their children's developmental needs.
Thank you, Dr. Isa, for stressing the role of the family, and that every program is unique and it's really dependent on the assessment on the baby. So for our viewers now, I just want to remind that this thing cannot be postponed. And as Dr. Isa said, if you can, we can do the catch up as early as possible, then of course the baby will benefit from this intervention. Now, before I go on to management of the children as they grow older, I want to go back to Dr. Isa, and maybe I can have now both Dr. Isa and Dr. Lorna in the panel, and maybe just go through a couple of questions that have been forwarded to us, because these children will eventually grow up and grow up and become adults of society. So maybe if each of you can answer the question like how do we transition these children in terms on the point of view of the endocrine part, and then maybe for developmental? Is there such a thing as transition to adult medicine? I'll start with Dr. Lorna before Dr. Isa. Dr. Lorna.
Yes, we now have, well, for the charity patients in PGH, we have a transition program with the adult endocrinologist. But in private, I personally endorse to the adult endocrinologist when the patient reaches the age of above 19. So I usually call up personally the endocrinologist, the adult endocrinologist, make a summary of what happened to the patient. And then I tell the patient, kahit na 1 year earlier pa, siguro when the patient is 17, I already start bringing in the idea that when you reach 19, I will no longer be taking care of you, but I will be endorsing you to an adult endocrinologist, because there are other problems after the age of 19 that I may not be very good at taking care of. So I personally endorse my patients, yung private patients, to an adult endocrinologist. And in PGH, we have our transition program as well.
Okay. That was one of the really good things that happened in the Department of Pediatrics, working with the adult medicine in coming up with the transition clinics, because like just for the newborn screening program, they will grow up and they will have other medical problems once they're no longer children. So for Dr. Isa, because assuming that we have a patient with red flags and started the unique program, what happens when they are still, they're retarded and they become adults? Is there another group who will take care of the patients? Dr. Isa?
Okay, so thank you for that question. When we talk about transition, we're really pertaining to two aspects of transition, and Dr. Lorna has discussed the first aspect of transition, which is the transfer of care to an adult healthcare provider. So this is not a mere transfer of a patient to another doctor, but it is really a process, as Dr. Lorna described, preparing the young adult to have greater independence in self-care and participation in his health management. And as pointed out, an adult will have new medical concerns, new medical issues that another specialist should be better trained to handle. Now, the second aspect of transition is moving towards adult-oriented activities and roles. And this is where it is important to discuss what are the transition goals for individuals who have intellectual disabilities. So we know that all individuals, regardless of their disability, have the right to a meaningful and purposeful life, fruitful relationships, and community participation. So for individuals with intellectual disabilities, particularly those who have congenital hypothyroidism that led to this disability, ensuring this usually takes careful planning with a multidisciplinary team. I would also like to make special mention of the initiative of our past PGH director, Dr. Carmelo Alfiler, for the transition programs in PGH, which was established across several subspecialties, pedia, endo, and IM endo included. And I am also currently the consultant coordinator for the Team Clinic for youth with developmental disabilities. This is a first in our country.
So thank you, Dr. Isa, no, stressing the role of the multidisciplinary approach to the management of the patient. But as we've said, if that baby was screened and diagnosed early and on time, and treated on time, and with the proper dosage, then we may not need to see actually Dr. Is a long term. But as I said, this is still a big challenge in our country because having run the program for 25 years now, and it's really hard to it really when we see patients with CH who were diagnosed with from screening, cases of CH picked up during the program and not receiving the right management, it really pains to see that they are having the problems and complications of developmental care. Now, let me ask a few general questions for both of you again, and because in the midst of this pandemic, with regards to immunization, Dr. Lorna, any words on should our patients with CH be receiving the required immunization or the vaccines that we are discussing right now?
Immunization for children with congenital hypothyroidism is the same as for the child with no problem, the healthy, normal child. So there are no contraindications to vaccination. They can receive all the vaccines available out there.
Hanggang adult. What about Dr. Isa? Is there anything else you'd like to add on that one?
Individuals with developmental and intellectual disabilities are at a higher risk for behavioral problems and mental health issues. So we also monitor behavior and mood aside from milestones. But hindi naman po lahat ng may congenital hypothyroidism ay nagkakaroon ng behavioral problems. Pero bahagi din po ito ng kailangan i-monitor.
So, and any final points you'd like to raise? Did we miss out on anything, Dr. Lorna and Dr. Isa, related to congenital hypothyroidism?
So, well, for my final word, it is really important that newborn screening should not be deprived to our newborn babies, and that to increase probably the chances of our babies being screened is during pregnancy pa lang. We should call upon our OB counterparts as part of their counseling for pregnant mothers is to already bring up the idea of screening so that they can prepare for it, although we know that it is free with the PhilHealth, and that once diagnosed, treatment should not be missed. They should continue their treatment, and that follow up with their local pediatricians or healthcare workers should always be done to ensure normal adulthood, because these children can become mothers themselves. And more so when they become pregnant, these congenital hypothyroid mothers should have an increase in their dose, in fact, because there is an increased requirement for thyroid hormone during pregnancy. So it is important that they bring the attention of the obstetricians that they have congenital hypothyroidism. So newborn screening is a right. Nobody should not be deprived, because early early diagnosis and early treatment will lead to a normal child and normal adulthood.
Thank you, Dr. Lorna. Dr. Isa, any final words?
I wanted to share some data from the outpatient clinic of developmental pediatrics in PGH. So I was able to call our census from the past 5 years, and I've seen that we had 172 consults for patients with congenital hypothyroidism since 2016 up to 2020. And our youngest consult was actually with a 4-month-old baby, and the concern was for motor delay. Our oldest patient was 19 years old. And these patients received a preliminary diagnosis of global developmental delay. And eventually, at 5 years of age, they were formally diagnosed to have varying degrees of intellectual disability.
Well, thank you. Thank you for that information. So maybe just can I have a line from each one of you? You know, one thing that you want your, if I can just request Lorna to say those final words again, just one line that you want your viewers to remember about newborn screening and congenital hypothyroidism. Can I request you to say it again, Dr. Lorna?
Okay. Newborn screening is a must. It is a privilege. It is a privilege for the newborn, and it is the responsibility of the mother and the physician that all our newborns should undergo screening.
Thank you, Dr. Lorna. Dr. Isa, the final word.
The newborn screening program in the Philippines is a major success in preventing neurodisability associated with congenital hypothyroidism. Kami pong mga developmental pediatricians, we are very strong advocates para sa early detection at early intervention. And newborn screening is the earliest one can get in detecting and treating conditions that affect a child's neurodevelopmental outcome.
Thank you very much to our panelists for a very lively discussion on congenital hypothyroidism. Thank you, Dr. Isa. Thank you, Dr. Lorna.
Kaya dapat magpa-newborn screening. Newborn screening.
Congenital hypothyroidism is the most common preventable cause of intellectual disability. Most children born with congenital hypothyroidism who are detected early and treated timely and adequately grow and develop normally in all respects. To our virtual audience, please send us your comments, questions, or list of topics that you want us to cover in our succeeding episodes. Email us at info@newbornscreening.ph or you might tweet us at newbornscreening.ph. And also the hashtag ENBSPH. Before we end, I want to again take this opportunity to present to you the new addition to our tools in learning, our ENBS mobile app. The ENBS mobile app is a one-stop hub for all newborn screening health workers on everything they need to know about newborn screening. It also features a rewards program that our health workers can use to earn points and use it to claim shop vouchers with our partners. If you have already downloaded the app, answer the quiz that we will send to your inbox to earn those points. We continue to improve our services as deemed necessary by the emerging challenges through an open dialogue about our experiences in newborn screening. It is our hope that through this program, we extend the sharing of knowledge with greater reach, empower our frontliners, improve connectivity with the newborn screening coordinators, and most importantly, provide unparalleled service to every family. For our next episode, we will discuss another endocrine disorder included in our expanded newborn screening panel. This and more here in Newborn Screening in Focus. Nothing is more precious than seeing a child grow healthy and normal. Let's realize this through newborn screening. Newborn screening is a gift of life.
Mula sa sinapupunan, 9 na buwan ka naming inalagaan. At ngayong nandito ka na, di ka namin pababayaan. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Love na love ka namin, kaya ito gagawin. Para sa kalusugan mo, dapat natin tong sundin. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening. Oh, aming baby, isa kang blessing, kaya dapat magpa-newborn screening.
Napakadali ng process na magpa-NBS. Ilang patak ng dugo ang kailangan para magawa ang test. Makalipas ang 24 oras, pag si baby lumabas, gawin natin ng NBS, alin sunod sa batas.
Oh, aming baby,